Hey, I think we're good to get started. We're at time now. Hi, everyone. My name is Alex. I am one of the community resource specialists at the Canadian Alliance. It's very nice to see all of you. It's my very first conference, and I'm really excited to have so many faces here, and hope I see some of you later and say hi. So this is, again, OS1. This is Bridging Healthcare and Housing via Innovative Discharge Practices. No, come back. It's too late. We saw you. Okay, we are here with, we've got first up Alex and Jesse, who are in the middle here, and they are here with St. Paul's Hospital. We've also got Bridget and Taylor at the end there, and they will be going second with Jasper Place Wellness Center. And we've got Ben Appleby as well from Outflow Ministries, who will be presenting as well. Before we get started, though, I do want to just provide a land acknowledgement. We would like to begin by acknowledging that the 2025 National Conference on Ending Homelessness is taking place on unceded Indigenous lands. The I'm so sorry, I'm a little nervous. The Ganagahaga Nation is recognized as the custodians of the lands and waters on which we gather today. Montreal is historically known as a gathering place for many First Nations. Today, it's home to a diverse population of Indigenous and other peoples. We respect the continued connections with the past, present, and future in our ongoing relationships with Indigenous and other peoples from coast to coast. Also, just wanted to point out before we start that there is simultaneous interpretation headsets available. You can get them in the level 2 or the level 5 foyer. We are on level 5, so if you need them, you would just head back out and grab those, and feel free to come back to this room at any point in time. We will be spending 20 minutes per presentation, and then at the end, we'll have time for questions and answers. So I'll flag that when we're there. Otherwise, we are good to go. Want to come up? Is this the correct slide? Yeah. Okay, perfect. Thank you. I'm just gonna grab a seat.
Hello, my name is also Alex, and this is Jesse. And we're here presenting the St. Paul's Hospital Medicine Outreach Navigator and Reaching Home program. So I'd like to acknowledge that the land in which we are visiting from is the traditional, ancestral, and unceded territory of the Coast Salish peoples, including the territories of the Musqueam, Squamish, and Tsleil-Waututh nations, whose historical relationship with the land continues today. And as social workers, we believe it's crucial to recognize and reflect on the harmful and historical role that social work has played within colonial systems. So how are these two programs developed? For context, Reaching Home and the Navigator are different programs, but they have similar goals. We're embedded within the hospital care teams, and we often collaborate with each other to support some of the more complex patient discharges within the hospital. The St. Paul's Hospital Outreach Navigator position is part of a pilot project made possible by a donation from Staples through the Even the Odds campaign. The role was developed based on the Navigator program established at St. Michael's Hospital in Toronto. I think some of the team are here today from Ontario as well. The St. Paul's Hospital team worked really closely with the St. Michael's team to replicate the program in Vancouver. And they're also now helping roll out the Navigator program in Montreal at CHUM, which is pretty exciting. So how does the Navigator program work? Oops. Not used to the clicker. So the unit social workers within the hospital identifies patients who would benefit from the Outreach Navigator support. These patients are unhoused, not well connected to other supports, and may have complex health needs that require follow-up. So they may have like new medical illnesses that they've not ever had to manage, and oftentimes they have multiple hospital presentations or admissions. The Navigator will then meet with patients in hospital to understand their personal goals, discharge summary plans, and outpatient appointments. So they'll also take this time to build rapport with them, be at bedside, and kind of get a sense of what the patient needs. And then the Outreach Navigator will follow them for approximately 90 days post-discharge to help them transition from hospital to community. So the program's goals are really to enhance care transitions for individuals experiencing homelessness, to bridge the gap between hospital services and community support. This is a gap I think we've been long aware of. To ensure effective implementation of discharge plans, because we know that many plans can be hard to follow through or are oftentimes unrealistic for our unhoused patients. And we offer patients consistent advocacy both within the hospital and throughout their transition to community-based care. So patients know that they can there's someone that they can reach out to with questions about their discharges or their upcoming appointments. And we have access to their charts and their files. And they also know who to ask for if they are readmitted back into hospital. So on this slide, there's just some examples of ways that the navigator supports patients. Some of the examples are connecting them to primary care, bringing them to follow-up appointments, liaising with other healthcare staff, helping connect them to longer-term supports and finances. And of course, more and more as this role was developed, we noticed that the impact of being housed on the patient's outcomes, health outcomes, which is fairly obvious, right? So alongside the medical care and getting people to appointments, housing became a big priority within the navigator role at St. Paul's. The navigator also helps patients figure out their pharmacies and prescriptions. It's often a small intervention, but it can be the difference between getting medications and recovering or having to go back to hospital. So an example of this, I once had a patient who went to a doctor's appointment. He had never had health issues. He was a fairly young guy. He had never had a family doctor. And after the appointment, he texted me a picture of his prescription and asked me, what do I do with this? I explained to him what it was and told him where to bring it, and then he laughed about it the next time that we saw each other. So all in all, like a very simple intervention, just a text message. The navigator also has flex funding to be able to support patients. So this can be used in a variety of ways. Paying for IDs, purchasing a phone to get in touch with them is really important. Paying a damage deposit if we do find housing. We've even purchased like work boots for someone who's hoping to go back to work. I'm going to pass it off to Jesse now.
That's great. Thanks, Alex. Hi, everyone. My name is Jesse. I'm a social worker with the Reaching Home Project with Providence Healthcare. And just thanks very much for being here today. We appreciate it. So one thing I want to mention maybe before I start is Alex and I will be referring to Providence Healthcare and St. Paul's Hospital during our presentation. And so Providence Healthcare is the larger organization. It administers healthcare-related facilities and programs in Vancouver, and St. Paul's Hospital is one of those facilities. So the Navigator project that Alex works on is based in St. Paul's, works exclusively with St. Paul's patients, whereas the Reaching Home project, which I'll describe now, works very closely with St. Paul's, but will work across the entire organization itself. So, what is Reaching Home? So Reaching Home is a initiative of the federal government of Canada, and it's a community-based program aimed at preventing and reducing homelessness across Canada. So for the project that we have, the funding is provided by the federal government of Canada, but then at a regional level at within the Lower Mainland, it's administered by Luma Housing Society as well as the Van City Community Foundation, and we're very grateful they help us in many ways with the program itself. And lastly, we began operating itself in September in the fall of 2024, and we have funding until April 2026. So we are a pilot project. We do hope to reapply, but we're still in that process. So the team itself. The team consists of 2 social workers and 1 peer support worker. The social workers will manage referrals, perform case management, administer funding requests, as well as provide reporting to our funders. and our peer support worker who provides invaluable contributions for the team, assists with patient rapport, engagement, as well as outreach, appointment accompaniments, and resource connection. So the project itself will prioritize support for individuals who are unhoused, insecurely housed, or at risk of eviction. And the real focus is to provide temporary and timely interventions that promote long-term housing stability. This can be done while patients are still in hospital and then continued once they're discharged to community. So within the team, we have two main streams of support. We have short-term case management and outreach support, as well as temporary financial support. So for the short-term case management and outreach support, the team will frequently work with patients who are transitioning from an inpatient setting, frequently St. Paul's Hospital, into the community. But we will also work with folks who are engaged with Providence Healthcare outpatient services as well. And so to avoid the duplication of services, we typically will redirect or connect individuals who can already access appropriate support from other community resources, or outreach follow-up can be provided by another team. So accepted referrals for the case management stream of support tend to be patients who are not eligible or not able to connect with already existing services. And our case management typically lasts for up to 90 days. That's not firm, but that's sort of the general, the general guideline. So for temporary financial support, this would be for patients that are requiring financial assistance to preserve their current housing or to prevent imminent eviction, to help secure new housing. So this can relate to housing startup costs that can be costly, as well as shelter diversion. So this would include providing alternative, secure, sheltered accommodation other than shelter. So in terms of what this may look like in practice, from the case management element, we work directly with community shelters. We seek short-term private housing options as well as long-term subsidized and market housing options. We can liaise directly with landlords, clarify housing concerns, and then develop action plans to address them. We can accompany individuals to housing interviews, but also appointments that are related to financial, medical, or food security elements. And lastly, we would help connect folks. We can help connect folks with new community resources as well as follow up on discharge plans from hospital. So next, with the financial support, we have we can provide support for unexpected costs that place a person's housing at risk. So this can be more specifically when there's an unexpected change in income. So if someone is switching benefits, or if there's sudden unemployment, Reaching Home can step in, provide temporary support to help individuals through that time. We can also provide partial or full rental arrears payment. That would depend on the amount owing, but if it is a partial arrears that we are seeking to pay, we would also negotiate a repayment plan for that individual to maintain their housing. We can also pay for cleaning services. This is to avert evictions, prevent evictions, but also to expedite discharges from hospital to community. So if someone is ready to be discharged from hospital, but there are some issues with their suite, we can pay for cleaning services to expedite that. As well as for individuals who've obtained new housing, we can provide basic furnishings for them. So this next slide focuses on, I guess, the dynamics and the interplay between many of the actors and the resources that are involved in patient discharge and patient care. So it also shows the referral process frequently relies on continued involvement from the referring social worker as well as the resources that are frequently accessed below. And I'll discuss those further on the next slide. But as you can see, as a maybe I'll use the pointer here. As a referral comes to reaching home, it is not always a linear process. It's frequently the referring social worker will remain involved. We can provide ongoing consultation with them. We can provide shared care, or potentially for a one-off request for support for a patient. Right, so on the next slide here, you can see the three sources of support here on the bottom. I'll discuss here in this next slide. So we have the first two are two existing and instrumental resources for support and patient care in the community. The first is the Transitional Care Center. So this is a short-term transitional shelter for patients discharged from St. Paul's Hospital. It is located in the hospital, and it is exclusively or almost exclusively for individuals who are leaving hospital and needing time to bridge to existing resources or further accommodation. Stays typically last 1 to 2 weeks, and it allows an opportunity for reaching home to meet individuals there and potentially develop initial housing plans. The second is a housing and financial liaison. So this is, we have a direct contact with workers within housing and financial organizations and agencies. With written patient consent, we're able to contact them. We can initiate housing or financial application processes, as well as update patient files or receive updates from these individuals. So it really does create an ease of communication that allows us to better coordinate client care, as well as a direct line of communication to better advocate and support our patients. Oh, sorry. So once housing and healthcare needs are identified, and these already established resources have been explored first, should there be any gaps for support for clients, this is where Reaching Home can attempt to fill them. So by doing this, with the last element of this slide, the local organization and businesses, we've tried to forge new relationships with local businesses and organizations to fill those gaps in service. So we have a relationship with a hotel furniture liquidation warehouse. This for individuals who are needing to furnish their places on a budget, that they can provide that service with delivery. As well as a cleaning and pest control service. This can allow us to plan for, to prevent evictions, as well as expedite hospital discharges, as I mentioned, as well as temporary accommodation that are other alternatives than shelter. So we have a connection with an affordable downtown hotel that can provide temporary accommodation while other options are sought, as well as a shared accommodation temporary housing service. So this is a service that provides furnished houses and furnished rooms, and you rent the room on a month-to-month basis. So Reaching Home doesn't seek to replace these existing resources or any existing resources for pathways or pathways for funding and other sources of support. But the intention is to try to supplement and build upon them, adding to the overall pool of options for patients with unstable housing and/or complex health needs. Okay, sorry.
Sorry, we're like musical chairs. So we always want to, we're 2 outreach teams embedded in the hospital, but we also want to acknowledge the existing outreach teams in the community. The Downton East Side especially has had longstanding, well-established teams like the overdose outreach team, intensive health outreach team, Indigenous health outreach, all the clinics in Carnegie. So there's so many that have been doing the work for so long that kind of paved the way for us to make it easier to be between community and hospital. I guess we're going back and forth.
So the Reaching Home and Navigator programs, they're distinct from one another with very core focuses, as you can see, but there is overlap in how we regularly support our patients. So the Navigator program, it will focus on connection to primary care and additional medical supports in community, as well as follow-up medical appointments. This includes various forms of outreach, as well as helping navigate new health diagnoses should they present. For Reaching Home, the focus is on housing setup, as I mentioned. So this includes furnishings, damage deposits, also short-term rental assistance. This can be a temporary subsidy to help someone maintain their housing, eviction prevention, shelter diversion, which would include the temporary accommodations that we mentioned in the last slide, as well as basic needs. So we can provide gift cards for individuals related to housing security and basic needs. Then, as you can see, the overlap, these are elements that we can and do both perform. So that includes housing searches and advocacy, connection to new community resources, liaising with housing and financial agencies, ensuring that financial and medical benefits are realized, as well as investigating or looking into available food security options.
I think like one of the strengths of both of the programs is that we're quite flexible, which is often thought to be fairly hard in an acute setting, right? Where it can be kind of rigid in the hospital and there's plans, but we're fairly flexible with the patients. We can follow them kind of through their ups and downs. For example, a patient may have multiple hospital presentations, but our work stays consistent. We'll follow them down to the ER if they're back there. We have a bit more knowledge about their history maybe out in community too. That's pretty valuable to share with like the attending doctors or other care members. Also another strength I think is just the timely intervention. Our integration within the hospital is what makes the role unique. So healthcare providers can identify psychosocial needs pretty early, and the hospitals present as a unique opportunity to support patients in a critical time. We have like the charts, we have psychosocials, we have all the functional assessments and allied health insights. So it gives us a better picture of how to support these patients. We already have these tools and how to support them in community. The Reaching Home and Navigator programs make use of strategic, well-timed interventions, supporting stability around patient health and housing needs, and potentially contributing to overall reduction of costly health and housing crises in the future. I'm going to do a little case study kind of to give you a sense of what the Navigator role has done or can do. So I met Mr. Chu when he was being discharged to shelter. He was very, very isolated and he only spoke Cantonese. He had a complex chronic pain issue that became so unbearable that he couldn't work and he lost his housing as a result. He was in and out of hospital and the doctors were really struggling to find the source of his pain. His pain became so bad that the Navigator supported him through his MAID requests and assessments. As he went from shelter to shelter, we worked together to find him a family doctor and to get him to his follow-up appointments with the rheumatologist. The Navigator brought language translation services along to make sure that he understood every appointment, which I think was a barrier to him throughout his medical care in the past. The Navigator supported the patient in sending about 20 housing applications and letters of support. Eventually, months later, with many ups and downs, his care team was able to figure out how to manage his pain, and then at the same time, he was offered supportive housing in Chinatown. The first thing he bought were a set of pots and pans because he was so happy to be well enough to cook and to have access to his own kitchen again.
Great, thanks. And so now I'll give a case study of an individual I worked with the Reaching Home project. So we'll call her Miss Zed. So she's a 31-year-old female. She originally arrived in Canada as a refugee a few years ago and is now a permanent resident. She has been followed by the outpatient heart function clinic for a chronic genetic heart condition. So after multiple years of waiting, preparing, she recently received a heart transplant and was admitted to St. Paul's Hospital. In August of 2025, Ms. Zed was referred to Reaching Home by her outpatient heart function clinic social worker for support with temporary housing, temporary accommodation, and long-term housing. So, from the referring social worker, you can see here, Reaching Home was able to rely on their psychosocial assessments, as well as their identification of an urgent housing need with consideration of her health status. So following her post-operation discharge from hospital, she was residing in short-term housing through an organization that focused on cardiac care and heart transplants. Due to demand, though, this lodging was very temporary, is only for a month, and this was put in place to support with her recovery. So as an immunocompromised individual, shelter placement was not an option, which, as you can see in the bottom of the slide here, the transitional care center was not, traditionally that would be an option for an individual. With her case, it was not. And so this was largely due to potential risks of infection as well as setbacks to her recovery plan. So in addition to this, she is on a Persons with Disabilities designation. This is a form of income assistance in British Columbia. So she's on a low fixed income, which limited her ability to afford many housing startup costs as well as market housing rents. So through one of our newly forged relationships with a temporary shared housing accommodation provider, Reaching Home supported her in finding a private room with her own bathroom for 1 month, the month of September. And this provided greater control over the cleanliness and potential risk of infection. And then we were able to connect with a local MLA office that had been in contact with her for several months around her housing. So the MLA's office was able to with the support of the MLA's office, we were able to find an opportunity for a new housing co-op for her. This was a permanent, self-contained studio rental with a monthly rent dedicated for individuals on low fixed incomes or on monthly assistance. As we proceeded with the process of applying, Reaching Home was able to provide the co-op membership fee that Ms. Zed could not afford and the Ministry of Social Development and Poverty Reduction could not pay. We also helped her furnish her new suite. So since that time, Ms. Zed reports doing much better with improved health outcomes since moving in. And we feel this case represents and highlights the intersectionality of housing and health, as well as the role Reaching Home can play in diverting vulnerable individuals from shelter and other unsuitable housing, while also filling a gap in service that ensured her ability to secure affordable long-term housing. So with the involvement and support of the MLA's office, this housing opportunity would not have been identified and pursued. And without Reaching Home, the membership fee could not have been paid in full and this opportunity would have been lost. So without an initial relatively small investment to divert Ms. Zed from shelter to more suitable temporary housing and secure this permanent housing opportunity, her health and other housing outcomes would likely be vastly different.
So lastly, how can other hospitals adopt similar programs? We're all mixed up. So I guess what we're doing here right now, like connecting and learning with other health authorities or other places that are doing similar work. To learn about like the challenges and successes. I think we gave you 2 fairly optimistic case studies, but obviously there's lots of challenges in the role, and I think it's important to talk about when we're first getting started. I had a lot of help from St. Michael's just to, get started on what the important aspects of this role would look like in a hospital setting. So we've added the contacts to the MAP team, Jesse and myself on the next slide, to just reach out if you're interested in starting up a similar program. Also funding, obviously you need funding to do these programs. So we would just encourage you to apply for housing or outreach related funding, even if your hospital doesn't traditionally operate in these housing or outreach spaces. Earlier we talked a bit about how hospitals are a good place to identify housing issues early, and we also already have the tools to support psychosocial needs. So, and obviously we can't separate housing and healthcare, like they are intertwined. And also building internal support, so engaging the leadership in your hospitals or your healthcare settings, social work and clinical teams to highlight how housing stability supports better health outcomes in the long term. I've also included research from Dr. Jesse Jenkinson's with the MAP Center for Urban Health Solutions to support folks who are interested in learning more about the program implementation. And here are our contacts as well. Thank you.
This second one here?
Nope. Oh, yeah.
Second of the bottom one?
Yeah.
All you, do you want me to leave you a timer as well? Would that be helpful?
You
Would that
just
freak you out?
at me
Okay.
when we have
Yeah.
5 minutes left really fast.
Okay.
How do we?
Presenter mode.
Shit, now I'm anxious. I'm sorry. Slideshow.
You've got this. You're
I
more
don't know
tech savvy than
about
me.
that. Okay. Let me make sure. Yep. Okay. Perfect. Good morning. Hello. It's really great to be here in Montreal, surrounded by so many people who just want to do the next right thing. I'm Bridget, and this is Taylor, and we're from Edmonton. The work we're sharing today started with a pretty simple question. What would happen if 2 of our biggest systems, health and housing, were built around people instead of policy? Bridge healing is one answer to that question. It's a hands-on, human-centered model that shows what can happen when care doesn't stop at discharge and housing is seen as a part of health. This isn't just about one program, though. It's about the human way forward. When it becomes overwhelming, just do the next right thing. This is what it looks like when courage, design, and collaboration come together to create better outcomes for people and for the systems that are supposed to support them.
So as Bridget said, we're from Edmonton. It's a cold northern city in Alberta, and we're from the Jasper Place Wellness Center. The Jasper Place Wellness Center is an organization that focuses on health, housing, and employment. Everything we do is co-created with the people we serve, and everything we've learned is from the people we serve. So when we talk about housing, that came out of conversations with people being unhoused. When we talk about employment, it came from meaning daily activity that our residents needed. When we talk about health, well, that's our lived experience. Everyone needs healthcare, and that's how we exist in community. We see these 3 pillars as intersectional to one another and really important to how we exist in community as people, regardless of your lived experience or where you're from. So our mission is to be disruptors. We take that really seriously, and we approach risk really seriously because we don't want to live where we live now. Our neighbors are dying, and there's actually real solutions that make a lot of sense. So we're disruptors. We're going to focus on 2 systems today, housing and healthcare. That's why we're all here, as we just heard. And great work, guys. Amazing. In Alberta, sometimes it's minus 25. Often it can be minus 30 degrees. And there's many days of our year where it's minus 40. And because of that, our emergency departments have become the center of our crisis. So we have housing solutions, we have amazing supportive housing, we have great shelters in our community, but still, as you can see, thousands of people are going to our emergency departments. Why? Well, I think we know why. But when we do the math, that's a really, really expensive problem. I think that's around $26 million in 1 year. And that's just people going to the emergency department and leaving. So we're not bettering the situation. That's repeat visits at about $1,500 a pot. Now we look at the human part of this, right? 50% of the people we're serving have an acquired brain injury. The data from Alberta Health says if you're identified as being unhoused, 1 in 5 chance that in the next 5 years you're going to be dead. So this is an extremely expensive cost financially, and it's an extremely expensive cost on our humans. And we know how to do better. So we met a guy. His name was Dr. Louis Francis Cuddy. He's an emergency doctor in Edmonton at the Royal Alex Hospital. And this picture I have of him, he's pointing in the mayor's face at a business event. So I want you to keep that in mind as we go through the presentation. He is a go-getter. I often will say Dr. Lou is my biggest bully and my biggest mentor because he's constantly pushing us to do better, asking questions all the time. So this is a doctor who's working in emergency department. He is seeing the same patients, the same faces, the same stories over and over to the point where he will leave. And when he's leaving, he says goodbye to the same people and hello to the same people when he's coming back on shift. And as we just talked about, ka-ching, 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 that's a really expensive way to treat people. Dr. Lou approached us, sorry, Bridget, I'm jumping in here, and said, Taylor, Bridget, Jasper Place Wellness Center, can you use a housing solution that you have to approach this crisis? And we were pretty naive in saying, working with Dr. Lou, first and foremost. I don't know if any of you work with emergency doctors, but get out of the way. Dr. Lou approached us and we said, yeah, we think we can do something.
So like Taylor said, when Dr. Lou started sharing what he was seeing in emergency departments, we knew we couldn't be working in silos. People were getting stuck, discharged from the hospital with nowhere to go, ending up back in crisis. We needed a direct pathway from hospital to home, something that could live inside health system but be operated by the community. That's the idea of bridge healing. It's truly a collaboration between the Royal Alexandra Hospital Foundation in Edmonton, Alberta Health Services, the City of Edmonton, and us, the Jasper Place Wellness Center. Together, we build a really simple but thoughtful process. When someone comes into the ER with no fixed address and no acute medical needs, they can be transferred directly to bridge healing, often within just a few hours. When they arrive, the staff are ready. They're welcomed into a private suite with a locking door, a hot meal, and a warm and comfortable bed, and a space to rest. More than that, they find what's been missing for a long time: safety, belonging, and dignity.
See if I can get our video to work.
I think I have one more.
Yeah.
Most guests stay around 90 days, long enough to stabilize their health and routines before moving on. Our shortest stay, was 3 days, and our longest was 9 months, because everyone's path is different. As you can see, bridge healing was built intentionally, small, calm, and human. Each suite cost about $250,000 per door to build. It's a small space, but it has everything a person needs: the private bathroom, kitchenette, and a door that locks. It's simple, but it's full of dignity. In shelters, people don't live, they just survive. That's why we took this approach. These rooms are designed to be home-like and trauma-informed and private, so people can finally rest, feel safe, and begin to recover. The design is based on the Eden philosophy of care, which centers companionship, meaning, and choice, and teaches us that people are dying of loneliness, helplessness, and boredom. We believe bridge healing is the antidote. And we build these houses so they could easily transition into permanent residential housing in the future. Because when you build with intention, you build with people, not just for programs.
Okay, one more. Oh. 7, yeah.
Before we move on, we wanted to share the words of someone who experienced, what's not story?
Sorry,
That's okay.
we're confused. A little nervous this morning. Sorry about that, guys. So I'll jump in. So we got pilot funding from our amazing partners at Alberta Health Services, the government of Alberta. And part of that pilot funding included an evaluation. And this is what I think is the most important part. If we're going to do this work, if we're going to fill a gap between housing and healthcare, let's research it. Let's make sure what we're doing is intentional and has reason behind it. So the evaluation was done, and it showed a 76% reduction in hospital utilization, emergency department visits for when people were housed through the program. I'm sure everybody, thank you. That's basic though. I'm pretty sure everyone in this room knows that housing leads to less visits in the emergency department, especially if when we're dealing with weather that's minus 35. So very simple. But we also saw a reduction in acute stays. We also saw a reduction in how many days someone was in hospital. We have done an evaluation with the Alberta Medical Association. So let's prove our cost. If this costs money to do, which it does, it's an expensive program to run, let's see how much it costs in review of the data and how many visits people were making before. And the Alberta Medical Association proved a 3-to-1 cost savings on the program. So if we invest in housing and we invest in people, we're gonna save dollars from our larger ministries. We had a 92% client satisfaction and an 84% emergency department staff reported reduced stress. So there we go. Beyond that, the data wasn't enough. We were proving it out, we were getting momentum, and we were showing our partners that it was working, but our pilot funding was running out and we weren't sure what we were going to do. We worked with the Alberta Medical Association, as I said, and that third-party business case had outcomes. It showed that we were doing what we needed to do. We were meeting repeatedly with our partners, but we kept being stopped. And I think the two things that stopped our momentum were working in a large system. So when you're working in a large system, there's fragmented accountability. Housing, healthcare, usually in 2 different streams. So as we're meeting with our funders federally, we're meeting with our municipal partners, and we're meeting with our provincial partners, individuals understand. Individuals see the heart, they see the data, and they understand that something needs to happen. But when you're working within large systems, you can get trapped in those large systems. So people got it, but there's fragmented accountability. Then there's risk aversion masquerading as process. Of course, we need to go through the right processes. We need to wait for funding to open up. We need to wait for budgets. But as we're waiting for those things, people are still dying outside. So how do you mirror and match that tension? Extremely difficult to do. And that's where Dr. Liu comes in again. As a funded organization, I have to respect all of my funding partners. I can't always bite the hand that feeds me. I have to ensure that I can maintain a good working relationship with our federal partners, our provincial partners, and our municipal partners. Hard to do though when your pilot funding is running out. You know the names and stories of these beautiful individuals. You're seeing an impact in your hospital. So you need to advocate. Dr. Liu spent all of his social capital. Let me tell you, the picture of him pointing in the mayor's face wasn't for nothing. That was at a business event with about 1,000 people. He stood up on stage, went directly into the mayor and said, "Give us land. We need more buildings. We're operating at too high of an occupancy rate. We know this works." Months later, we get land. So the city of Edmonton stood up. They did that for us. The Royal Alex Hospital Foundation said, okay, well, the city's giving you land. I guess we will start a $10 million campaign so that you can ensure you can build these buildings. And if one of your partners doesn't come through, we'll do a priority needs campaign. So you could use some for operational if you needed to. That was beautiful. And as our pilot did come to a close, our provincial government, they stepped up. They said, yes, Taylor, this might not be housing and this might not be exactly healthcare. It's a mix of the two. We see the data, we believe you, and we'll go for it. But I want to be very clear. Dr. Louis Francis Cuddy was showing up at meetings he wasn't invited to. He was going to council events he wasn't invited to. He was accosting people at coffee shops that he might just happen to be at as a minister walked through the door. He used everything he had to push this program forward because as an organization, we were kind of trapped.
Okay, before we move on, we wanted to share some words of someone who experienced bridge healing firsthand. Stories like this remind us of why the work matters, because behind every policy or program, there's a person rebuilding their life. This guest message was written as a thank you to staff and everyone who played a part of their journey. It speaks to what safety, dignity, and connection can make possible when someone finally has a stable place to land. The guest letter goes as follows. I would like to take this opportunity to first and foremost thank the frontline staff here at Bridge Healing. Your professionalism and work ethic were remarkable. I really appreciate your diligence, your patience, and your advice to me. To the support team and management, thank you for giving me the opportunity to rebuild myself, for giving me a stepping stone in my life. Homelessness should never be taken for granted, and now I have the chance to hold my own key to the future without worrying about a roof over my head. Thank you to the housing team. You accommodated my needs so well. You even met my nutrition demands, no salt, no dairy, and I thank you. I felt very safe and secure. Thank you to all and bless you abundantly. I'll surely miss the company of staff, especially during the hockey playoffs. You respected my space and supported my health. You checked on my wellness and I'm grateful, especially because of my hypertension. Last but not least, I would like to thank the Jasper Place Wellness Center and Alberta Health for taking me in. I leave here far better than I came. I feel healthier, stronger, and I leave with more than 2 suitcases I arrived with. You gave me stability again. Thank you to all.
So, like every story you're going to hear over your time at the conference, it comes back to someone making a choice. Bridge healing happened because people used their position to do what systems wouldn't. We had the data, the outcomes, the proof, but it was people who moved the program forward. If you hold power, use it. If you hold influence, spend it with intention. Every community needs leadership that moves without permission. Be that leader. So we want to leave you today with 3 things that you could use in your community to do bridge healing. So we have our implementation manual available. It's on our website. You just follow this QR code and it will give you early learnings into how we started bridge healing. Then we have our business case review, which I hope you take a look at and use with your ministries wherever you are working. This is real data and has real outputs. And lastly, we have our evaluation, which I hope you also take a look at. It shows the data points I mentioned, but it also shows you that we do fail too. There's lots of room for us to grow and lots of room for us to do better. There's people we're not serving very well, and we need to improve that. And I hope that we can learn from people like you when you start doing this in your community. So thank you for listening to us and have a great time.
All right, thank you for coming to the session. I'm going to put a disclaimer right now that as of 2 days ago, I had 40 minutes to present. And then I came yesterday and found out I had 20 minutes to present. So I'm going to skip through some slides, hope you don't mind. I want to just hit some of the highlights. We're talking about bridging the gap between healthcare and housing. I just want to talk mainly about a project that we're launching in St. John, New Brunswick that we're really excited about. We're confident it's going to be a success, and we really hope that we're able to scale it up across the province and elsewhere, wherever it's needed. And so hopefully it's a good model, provide some learnings for you here, and be able to take some notes and bring that back to your community and apply it. I want to talk a bit about, my name is Ben Appleby. I'm the Director of Shelter and Housing at Outflow Ministry. So I just want to give a bit of a brief overview of Outflow. We've been around for about 17 years in St. John, New Brunswick. Really started out as two individuals just walking around Uptown St. John. We call Uptown St. John, it's the downtown. So I don't know why it's called the Uptown. I've never really got that. But walking around Uptown St. John, trying to meet tangible needs. They both were a faith-based charity, so they had a heart for street ministry, really asking people what they needed, what were the gaps that needed to be filled. And so started out as two guys. They're our co-executive directors today, has turned into an organization that now employs over 60 people across 3 main sites. Those sites include our Outflow Men's Shelter. Started out, we've had that for about 10 years. The Salvation Army used to run the men's shelter in St. John, and their contract had ended. They chose not to renew it. So looking for organizations to raise their hand, and for some reason we raised our hand. And so we started out, it was a 20-bed shelter 10 years ago, operated 12 hours a day. Now we're up to 46 beds based on the need and demand. It's not enough anyway, but we're up to 46 beds now. We operate 24/7. Our main building, forgive the picture. I took this the other day because we didn't have any pictures. The paint job's not the greatest. We're working on a bit of TLC, so it doesn't look the best. But this is our main building. It was a funeral home, actually, for 100 years in St. John. And the group that owned it has several funeral homes in the province, like 30-something funeral homes. So didn't really use this one anymore. It was an older one and didn't get much traffic. So they wanted to donate that building, donated it to us, wanted to see it fulfill continue to be a place in the community. To kind of still be in a mission to the community, so they donated that to us. And we have done some renovations to it. We operate, there's 3 apartments upstairs, multi-bedroom affordable housing units that we partner with another frontline agency that supports vulnerable women reuniting with their children. And so we make those apartments available to them. Main levels, mostly offices, and then downstairs we have our 24-hour drop-in center that we launched 2 years ago. That was part of an extension of the Out of the Cold kind of winter response to homelessness. Traditionally, we've had Out of the Cold shelters pop up just for the winter months, and then they run for a few months, and then close down. So the provincial government wanted to continue that response throughout the year, and so created this 24-hour drop-in center where people can come in, get out of the elements, get a snack, get some coffee, but it's also meant to be a service hub. So we offer mental health support through a mental health nurse that's there a few times a week. We have a team of health professionals, nurse practitioners that are there every day as well to provide health supports, and we also offer trauma-informed counseling, individual and group sessions, and we're continually trying to build that. We, a few months ago, started handing out income assistance checks once a month there as well, so that people who are already there accessing services can then pick up their check. We have a social enterprise coffee shop we launched in 2019, right at the tail end of COVID. Not the best time to start a business, but we've seen consistent growth over the years. This is a building that was donated. This is going to become a theme that was donated to us from the Anglican Diocese. It was the bishop's office and a bookstore, and they weren't using it anymore. Again, wanted to stay in local hands and still be in some sense of mission to the community, so donated that to us. We spent a couple years renovating it. And this was going to be, if I had more time, a real plug for our coffee shop. But have a great space. We did a lot of renos to it over the years, and it's a comfortable, warm place to be. And it provides a consistent source of revenue for us so that we don't have to typically rely on public funding or government funding. So we're also trying to grow that. We had another church building that was donated to us by the Anglican Diocese. It was closing down, and instead of tearing it down, they wanted to see it stay in the community. So we always say yes. I don't know why we do these things, but say, do you want it? We'll say, sure. We don't know what to do with it, but we'll take it. And so we've run some carpentry employment skills training out of this building. It's a beautiful building, so we're at this point trying to turn that into a second coffee shop location where it's going to be more focused on food and event hosting, so we can hopefully pour some money back into the ministry. On top of those things, we run a food pantry, donation pantry, have seasonal donations that we have that is on offer every day. The core of our ministry over the last 17 years has been community meals. We continue to operate those community meals. We serve up to 800 meals a week. I think it's probably a bit more than that now. And so we just try to meet needs wherever they're at. And so we're always adapting to that. And part of that is shifting into this housing piece. 10 years ago, I've been at it around 10 or 12 years in this sector. There was no nonprofits that ever thought about, well, we'll build our own housing and develop our own housing projects. It was just not something you thought about. We don't know anything about property development. And now, because of the need and the demand with homelessness in St. John and in New Brunswick, we have a number of nonprofits that are like, well, we have to build our own housing because we're not seeing the rental markets taking off. We can't get private landlords to play ball with us. And so just a bit about St. John. Hands, who's been to St. John, New Brunswick? If you live there, you don't count. I know a couple are here, but awesome, a few. Certainly not that many. Understandable. Little blurb about St. John. I'm not going to get into a tourist advertisement here, but St. John, we have a population of about 80,000. That's in our downtown or our urban core. Greater metro area is about 140,000. Oldest incorporated city in Canada, founded in 1783. Fun facts for you to take notes so you can learn something today. The University of New Brunswick, our main university, is tied with the University of Georgia as the oldest university in North America. The modern vortex flushing toilet was invented in St. John, New Brunswick, and as was the time bomb. So there you go, write those notes down. You learned something from the session, very valuable. No, but to give a bit of perspective, 1951, our population was about 73,000 in an area of 36 square kilometers. Fast forward 74 years, the area that we support as a city has now grown by about 10 times. Our population has not grown to match that. And so I actually presented 8 years ago now on Housing First at the CAEH, and I had a similar slide, and the population in 2016 was actually less than it was in 1951. So thankfully we've seen a bit of growth over the last few years, really since COVID. And so hopefully that growth stays consistent, but we've had this large land area to support. We don't have the population to support it. So what it turns out to be is that we have the average income, individual after tax, 46,000. What was that? Sorry, did I get that wrong? 48,000. Households, 56,000. That's up to 20% less than the national average. We also have the highest low income rate in Canada. 1 in 18 people under 65 are on income assistance in New Brunswick. Average house price, as of 2025, 330,000. I know many of you in the audience, maybe particularly from Ontario and or BC, will say that's a really good deal. But it's important to note that since 2019, our average house price has increased by 80% in New Brunswick. So our housing market has taken off, but we've not had the incomes, not had the population to match and stay consistent with that. So a bit about our rental market. Our average income assistance rate, $675 a month. If you're on extended benefits, that can go up to about $940 a month. The average rent for a one bedroom right now is currently set at about $1,000 a month. That's the greater metro area. I will say that in the uptown core, that's probably higher than that. It's probably closer to $1,200 a month for the one bedroom and about $1,400 for the two bedroom. So affordability becomes an issue. Our rents have increased 35% since 2020. Let me look at my notes actually for that because I want to get that date right. %, from 2020 to 2024. Groceries and utilities increased by 20% over that same time period. So we've seen a great increase in our rental market. Our vacancy rate, when I actually presented 8 years ago, was 8.5%. Rental vacancy rate was the highest of any urban center in Canada, now sitting at 2% or less. And so when we were doing Housing First years ago, we had landlords calling us to be like, hey, what about these government subsidies? Can I get a government subsidy on this apartment? And now you're knocking on doors left, right, and center. We had 15, 20 landlords that used to work with us for housing homeless individuals, 8 years ago. We maybe have one now that has a social conscience and will play ball with us because the rental market's just taken off. So they can get way more on the market than they can being part of the rent supplement program. A little bit of a snapshot on homelessness. We've seen our chronic homelessness numbers double since 2023. Over the same time period, we've seen shelter occupancy rise by 62%, and we've seen a marked increase in visible homelessness in encampment sites since 2020, since right around COVID, and really become a hot button issue in St. John. I know it's a huge issue everywhere, but really become a social issue in St. John where the community is now kind of pushing back on it, really wants the municipal government to act on it, and it's really become a challenge for frontline nonprofits to support those individuals. I won't get into the shelter. We'll skip that one because we already talked about that. We see about 200 unique individuals throughout a year at the shelter, but we've seen this huge increase in homelessness numbers so that our beds now are 46 beds at the men's shelter, our 25 beds at the women's shelter, just not nearly enough. We have created a new shelter, a co-ed shelter in St. John. It was the Out of the Cold temporary shelter has now remained permanent, so we do have another shelter option for individuals who are living rough or living on the street. So this strain on the homeless system has crossed over, of course, into the bigger systems as well. So Horizon Health partnered with Dalhousie University Faculty of Medicine, another University of New Brunswick, a few years ago to conduct a study of 50 individuals who identified as homeless who were in hospital. And they were seeing this huge influx in people occupying ER beds who are homeless at a huge cost to the healthcare system. So they for about 3 years followed 50 people to see, like, what is this costing the system? What kind of strain is this putting on the system? So 50 people over 3 years accounted for 885 visits to the ER, 84 of those by ambulance, resulting in 205 admissions to hospital for a grand total of 6,035 days spent in hospital from 50 people who identified as homeless. The average for those 50 people was 2+ years spent homeless. So when we talk about a bit of math, I saw the numbers with Jasper Place Wellness as well, which is phenomenal, actually fairly similar, and it's really cool to see that from a different perspective. When we talk about money, we can take that number, 6,035 days spent in hospital. We can multiply that by what does it cost to be there. Estimates, we talked about around 1,500, was it? Estimates in St. John for an ER bed are given at about $5,000 a day if you take into account all the costs associated with it. Not all these individuals were in ER beds all the time. They were admitted to hospital sometimes, and they had a lot of times had come and gone very quickly without being seen by anybody. So we can take a conservative number of about $3,500 a day as a cost associated with being in hospital. We multiply that by 6,035. It's just over $21 million cost to the system for 50 people to be in hospital when they don't need to be there. These are individuals who are medically ready to be discharged. So it's a huge cost to the healthcare system. So what is a possible solution for this? Well, 2022 outflow, as I mentioned before, we operate a shelter at capacity all the time. What are we going to do about that? And so we thought, well, we got to build housing. And so we came up with a concept to develop a 6-unit project, affordable housing project, that was really at the time targeted towards our hardest to house chronically homeless men at the men's shelter. We'd seen some people who were living there for years and just hadn't been able to make it in a traditional apartment setting. And so we have the oldest public housing stock in Canada. So we have these old apartment buildings. I used to deal a lot with getting donations of furniture and to try to fit furniture into some of these places because the hallways are so old, the hallways are so narrow and small. I had 15 couches one time donated by a furniture company and we couldn't put them anywhere. They sat in the storage space because we couldn't fit them in any of these apartments. But these traditional enclosed hallways, close neighbors really just weren't working out. And so we thought, well, let's do something a bit different. I'd operated Housing First programs for 10 years. And so we developed this concept, kind of an open concept bachelor suite, where there wasn't any really enclosed spaces to hoard things or hide things. You could see the whole unit from the front door, so if you were doing an apartment check or a follow-up. Bathrooms were totally waterproof so that we could just kind of hose them down if we needed to. And so we were in the phase of developing this concept, and then our public health authority, Horizon Health, who had just finished doing this 3-year study, came to us and said, we see that you're building these units. Do you want to partner with us? We just conducted the study and found out that 50 people were accounting for 6,000 days spent in hospital. We need to get these people discharged so we can get these ER beds back to where we need to have them for the individuals coming in an emergency situation. So we thought, well, we have this huge inflow into the homeless shelter of people being discharged from hospital. It's a huge problem for us where we don't have medically trained staff. We have these people dropping off at the front door at the shelter. We're like, we can't do anything about this. This person shouldn't be at the shelter, so we send them back to the hospital. They get discharged again the next day. We send them back to the hospital. So it's this revolving door. So we said, well, this is a win-win for both of us here. We're going to cut down inflow into the shelter, and you're going to be able to free up ER beds at the hospital. And so we formed this partnership with Horizon Health, really spearheaded by them, which is a phenomenal thing for a big system, where now we're partnering we're creating a convalescent care bed program. So this 6-unit project will now be made available to individuals who are currently in hospital, ready to be medically discharged, traditionally have not been able to go really anywhere because they have no place to go, where they'll be discharged to their own unit and then followed up by a medical team for roughly 6 months after that. Make sure they continue to heal, continue to stabilize, and then after a goal of 6 months, it's not anything set in stone. If they're not ready, they're not ready. But after a goal of 6 months, they'll then transition from these units into a permanent affordable housing unit. And so we're working with our housing corporation, Housing New Brunswick, to make available 12 subsidies a year for us to use on traditional apartments. So we'll set them up, and we'll have a case manager employed by Outflow that will liaise with the health team, set those subsidies up with units, and then set up the move-in process for these units, and then hopefully transition them off. So theoretically, we could support 12 people a year out of this particular project. So they're all self-contained units, all have their own entrances. Layout's not going to do you much good for the details, but it's just a bachelor suite, about 320 square feet of living space. Easy to manage, easy to clean, easy to maintain, and in a place for you to be just to heal up and become stable and hopefully move on into your own subsidized unit for the rest of your days. And so we've been able to partner with, hopefully this will work. It's my own creation of a time lapse. There it goes, it even repeated. So we were able to partner with Kent Building Supplies. It's an Irving-owned company, and they have a subsidiary called Atlas Structures who builds things in panels. They just they bring them all flat packed on a truck. And we were able to partner with them where they offered us a pretty good deal to be able to come in and put those up. So we were able to, this is only 2 weeks ago actually, be able to construct this building in 2 days. We actually almost made it in 1 day. But we moved into the day two a bit. So one day there was nothing there, and the next day there was buildings there. And so we'll spend the rest of the fall here closing those in and making sure they're weather tight, finishing all the inside work, and our goal is to have occupancy in early 2026. Our subsidies with the government will start on those units in January, so we hope to occupy February, March, and have those 6 units occupied by March, April, right around there is the goal. And then we have a huge research piece built in through Horizon Health and the Health Authority where they're going to be following up throughout the next couple of years to monitor progress, and hopefully, theoretically, and we're very confident we'll see a marked decrease in ER bed usage by those individuals identifying as homeless. And we're hoping to also demonstrate a decreased inflow from systems, and particularly the health system, into the shelter system or into homelessness. And so if we're successful, which we're confident we'll be, we want to repeat this and scale it up across the province. Horizon, our public health authority, and we only have one public health authority in New Brunswick, wants to scale this up across the province. And so we're targeting about, we'll talk a bit again about, as we finish, about the cost savings. We're targeting about $100,000 a door for this project. We've been able to do it quite affordably. They're a very small footprint. They're actually built so that they can be transported on a trailer if they need to be, if they need to be built off site. We happen to own that land, so we were just built it on site for this particular time. But if we talk about a savings to the system, money matters. We talk about how can we save money doing this. It always perks the ears of those in these big systems, and certainly government officials, if we can say, well, it saves money too. It's really, obviously it's better for the individual, but it also saves a lot of money. Oh wait, did you say save money? So we take that number we saw earlier, the 21 million. So that's a 3-year study. So we break that up over 3 years, about $7 million a year. 50 people in the study. We divide that by 50. We come up with a rough cost of about $141,000 per person to be in the hospital. So you think about that number, you say, well, what does it cost just to house them then? And so we were targeting, as I mentioned, $100,000 a door, $600,000 for 6 units. If we're thinking about over that same 3-year time period, about $33,000 a door per year. If you take into account the subsidies provided by the government, which in New Brunswick end up being with the rent on these bachelors would be about $9.15 a month. So if the individual is paying 30% of their income towards that, the remainder comes to about $633. And so you multiply that out by 6 people, 12 months a year, you come up with just shy of $41,000 a year to house someone in their own unit. And that, if you do the math, is a savings of 71% to the system. So 71%. It's a big number. I was hoping for a few gasps, and And I really, really preferred this type of reaction. Because that's really, when you think about 70% savings, where it's like someone can be in the hospital that whole time, and they're receiving obviously lots of care in the hospital, but that's an institutional setting. It's not the most comfortable place to be, it's not the most dignified place to be, even though, they're getting the care that they need, but they're ready to be out on their own, or that's opposed to being in your own place to live. And so let's just shift the environment from someone being there to taking that healthcare team, bringing them outside the hospital, and then supporting them in their own place. And so that's the goal with this particular project. We're thankful it was spearheaded by the Public Health Authority. It's not as if it's something that Frontlines can't take to their health authority and say, you do the numbers. It's not that difficult when you take your own context locally with your subsidies that you have. Obviously in other places it's more expensive to build a building that may be in St. John, but it's also likely a lot more expensive to be in the hospital as well in those places. So even if we're talking, I know in this particular case we're saving theoretically 70% cost by doing this. It's a no-brainer. Let's build a bunch of them, and that's the plan. We hope to do that. As soon as we get this one closed in and weather tight, we're going to be starting to apply for funding for the next one. But if it's even, if it's parity between the two, a homeless person should have their own place to be that's dignified and safe and warm and stable, where they can heal. There's tons of data out there to show that if you're in your own housing as opposed to on the street or in a shelter, your chances of healing are far greater. Mortality rates drop through the floor. And so it's one of these things that it just should be common sense. And so we hope to demonstrate that. And I would love to have had staff from Horizon Health here to present with me, and hopefully in another year we can do a larger session where they can start to present those follow-up findings, and that's the goal, maybe next year, the year after. But it's a proof of concept. We're confident it's going to be successful. We're excited about it, and we hope to repeat it a bunch of times over. So if you think it's valuable to your community, then certainly feel free to ask questions, and I'll answer any questions that I can. Thank you.
Okay, we have got, it looks like 17 minutes for questions from the audience. We've been asked that folks use that mic in the middle there, just so that the transcription and translation can pick it up. I think maybe in the interest of time, maybe it looks like it's wireless. I'll grab it and run it to folks. So if you've got any questions, feel free to put your hand up, and I'll run that mic over to you. And just in case you need names again, we've got Bridget and Taylor at the end there with Jasper Place, and then we've got Jesse and Alex with St. Paul's Hospital, and then of course Ben with Outflow Ministries. Okay.
Can you yell?
I'll just talk really loudly. When you speak to cost savings, the first and the last presentation, oh, that was working now. Okay. So do the powers that be actually, accept that argument? And the way I frame it is that I see it a much better, like a better use of public resources. Like to say a 70% drop, or the other number of the first presentation, I can't recall what it was. But at the end of the day, if you don't have somebody who's homeless that is consuming hospital services, somebody else is going to be consuming those services. So the building housing and having the appropriate supports are ultimately additional costs to the state.
Romantic.
So like when you encounter that, because I'm sure you have encountered that argument, how do you deal with it? I mean, the moral issue aside, at the end of the day, it's going to take additional costs to get these people out of the hospitals and all the other services that they're consuming.
Is this on? Okay, it is. For us, that's a conversation that comes up all the time, is that it's just another cost that's going to be absorbed within the system. So you're exactly right. And I think that's where our advocacy comes down to. It's the right thing to do. We also need people out of emergency departments for other people to receive care. So when you live in a province like Alberta and your hospitals are your major trauma systems and centers, you need people to not be in those spaces when their main housing or main need is housing. So you're exactly right. It's not a cost savings. It's a push of dollars, and that's a conversation we are often having, and that's where it becomes the next right thing to do. So we might not be saving dollars because the emergency department will be open regardless, but if we can treat people with better care elsewhere and ensure other people get that immediate care when needed, there is a cost savings there. So the money part, as much as it is a wow and it can change things, in a health system, it is absorbed. So you're exactly right. And that's where the advocacy on a human level comes in for us.
Yeah, and I mean, I would just add to that, like in the New Brunswick context, I would argue that it is a cost savings to the system, and that's really why this came from the health authority to us. That's never happened before. They've talked about convalescent housing or similar type models over the years, but it's never gained traction, it's never taken off until they had done that study, because that showed that when someone doesn't have any place to go, they don't have a home to go to when they're discharged, then they just stay in hospital. So it disproportionately increases that usage by homeless individuals. But those same people have an average of far more comorbidities or health issues than the general person going in would do. And so I think in this particular study, the average was 3.22 comorbidities per individual. Mainly that was MRSA infection, Hep C infection, and then substance use disorder and other things. And so while they're in hospital, they're also consuming more resources while they're there than the typical person accessing the hospital would. And so if you're shifting that person out to be in their own apartment, which they're going to be trying to access once they're discharged anyway, but the health team's following them while they're there, so that opens up our bed for someone else. For the general population is going to consume less resources while they're in hospital, which would be a savings to the healthcare system. So their perspective is, let's lessen the strain on the healthcare system, which in New Brunswick, and I'm sure this is the same everywhere, is really at a boiling point. Like it's really, really a huge problem. We've had people pass away in ER, in the waiting rooms and those kinds of things. And so that's the goal from them. And then as soon as they saw those numbers, they're like, oh, what can we do about this? Let's partner with a community agency, which we've been asking you to do that for 10 years. And so, I mean, better late than never, but this is hopefully something that will prove to be successful, and then we'll still be able to, support them in community instead of in hospital.
Thank you.
Yes, hi. My name is Gabriel Paletta. I'm from Sherbrooke. My question is towards the Providence Healthcare team. I'm reading on your website that you're also a faith-based organization, but as an hospital, I was wondering what happens when a patient needs to be discharged because he requires medical services that the Catholic teachings do not agree with, or something like that.
So yes, it is. It originated as a faith-based organization. However, it is still provides health services in ways that any other hospital in Vancouver would provide. Given there are some caveats around that, but in terms of MAID and some other things, but those are still coordinated and folks are supported in those elements. But it doesn't impact the way in which medical services are provided.
Thank you. Love the work that you guys are doing. I have a quick question. How do you guys navigate substance use within the settings that you work?
I'll start with that, I guess. This particular initiative, individuals who are in hospital would be on some sort of substitution therapy anyway. They would remain on those from that health perspective if that's something that the medical team would deem necessary when they're coming in heavily addicted to a substance. That will continue through that process of transitioning into the unit where they would continue, if they're on a substitution therapy, then they would continue on that while they're monitored by the health team until they're ready to transition into their own permanent affordable housing unit. And then, of course, they're hopefully well enough to be on their own after that. But that would be, for this particular model, would be the standard at this point.
At Bridge Healing, we come from a harm reduction model as well, so people can use substances in the safety of their own room if they come with a substance use disorder. So we have staff on site 24/7 doing safety plans and making sure people are using in the safest way possible. At Jasper Place Wellness Center as a whole, we see harm reduction as a spectrum that includes usage as well as recovery. So without having those conversations in a non-judgmental space when people are using, they're not going to come to us when they're ready for recovery. So we just start with always the harm reduction base and always having conversations that navigate hopefully to some sort of recovery.
Within St. Paul's, so obviously Vancouver has been in a toxic drug crisis for a long time. Our hospital actually has an inhalation tent and a safe injection site, which has been a huge benefit to us and to the patients, and actually makes our work easier because people want to stay in hospital longer to finish their treatment. And so really like coming from a harm reduction model as well.
So I have a question for Ben. So I live in Nova Scotia and we have services there, and obviously we're in dire need as you were in New Brunswick as far as kind of bridging that kind of discharge into, you know, homeless services such as shelter. Would the healthcare provider in New Brunswick share their report, do you think, to other healthcare providers in other provinces, so that we can at least start to have that conversation at that level rather than us whining in their ear? They can see the numbers and the statistics.
I'm confident they will. I mean, I can't speak for Horizon Health since we don't have any staff here, but that's meant to be the whole purpose of this, is to research the crap out of it. And that's something we're very thankful for, because we, as a nonprofit, we always talk about knowing our data, and it's just so expensive to have these research projects built in. So to have them back that up, and they've got funding to do so, will be really encouraging to see the success of the project through. And then the whole goal is to make that obviously public and shared so that it's a model to be repeated. I mean, we don't want to keep this thing secret. If it works and it really fills some of these gaps, we start to see some healthy data, then let's do it over and over again elsewhere, adapt it to your community, and go with it.
Hi. Given that these projects are all fairly new, what kind of data is going to be collected afterwards in terms of maintenance and keeping people, keeping folks in housing? Like, is that the next step to show, like, we got them out of the hospital, we're keeping them in care now and in housing? Like, what would be a good statistic that you guys are looking for?
So for our project, people come from hospital to Bridge Healing, stay with us for a length of time, as we said. And we do have a research partner, Dr. Catherine Dong, out of the Public Health School at the University of Alberta, who is doing a long-term study. But I think it reflects more on the long-term housing projects that exist. So Bridge Healing is a transitional housing program that's going to connect people to housing first, supportive housing. So when you follow people long-term, you're not necessarily researching their time with us. That's going to be some of those other interventions in play. But for us, we want to see people housed in housing that meets their needs and is it part of their chosen community, because we know if those two things are met, they're going to stay there longer and health outcomes will be better. So we are doing a long-term study with Dr. Catherine Dong, and we hope to see that our housing programs that we rely on support these individuals as well to maintain that housing. But I think one program can't do all that heavy lifting, so we have to rely on all of those partners and have that data succinct. Will that happen? I'm not sure, but we're excited to have some long-term research on our program.
Yeah, and with ours, I mean, there's that research piece that's built into the health authority. So the main problem that initially spearheaded this was that disproportionate use of ER beds. And so, of course, that will be monitored then to see if that ER bed usage is decreased by individuals identified as homeless. And then once they move in, we would have, as the housing provider, our perspective will be tenancy stability. And so we'll monitor those numbers over time, certainly over the 6 months, that theoretical 6 months that they're in that program. And then, of course, when they transition off into a permanent affordable housing unit, then we'll make sure that that's monitored for housing stability as well, that they'll be, successfully handed off into their own place to live.
And then, excuse me, for Reaching Home, there is a built-in reporting element to it. So for anyone who's provided with prevention services or housing services, we follow up with them at 3 months and 12 months. And so because the program is sort of just passing into 12 months, we don't have much data on that. But in terms of the 3-month follow-up for folks that we've worked with, it is over 90% in terms of those who have maintained that same housing. And then Reaching Home itself is really focused is housing specific. Providence as a healthcare organization is quite new to actually operating a Reaching Home project. And so the health element is something that we're interested in terms of the great stats that both of the other teams here have presented. We're in the process of trying to collect that, but at the moment we don't. We're still working through it.
We've got time for one last quick question.
So just a question more around the transitional, like transitioning out of hospital into some of the units. I think it was transitional care unit, convalescence. Do you face challenges because it's meant to be short term, getting people out and how are you, like I don't really even know what my question is. I assume you have a lot of challenges with it, but how are you supporting the individuals? And yeah, how do you do it?
I mean, that's a great question. A lot of the time we don't know in the moment, and we just try to do our best to get creative. So, I mean, the one thing that's really helped us support folks is the fact that we do have a modest monthly budget, and so we can use our discretion to attempt to find new ways to house people temporarily that would not necessarily be available. So, I mean, one thing with our project is that because we're temporary, as soon as we start working with someone, we're always thinking, okay, what happens when we're no longer involved? Because if it's not going to set someone up for success or to help them to achieve like sustainable housing, then we need to adjust our plan. And so when I say that we work with folks short term in 90 days, that gets extended. If we don't discharge folks or we don't stop working with folks unless we have a soft landing space for them. It may not be ideal, but it will be something that will meet their needs and be suitable for what they're requiring. And then if it's not permanent, then we would try to put the supports in place that could then work on that for them.
And then with our project, originally when we had planned it for our more chronically homeless, hard to house guys at the shelter, it was permanent housing. I mean, the units were the units and you'd live there hopefully for the rest of your life. But it's 6 units, and so it's a drop in the bucket when you think about the overall needs. So Horizon, when they came to us, talked about a transitional model, and it really was based on their agreement with Housing New Brunswick, and Horizon's the only public health authority. They're a huge system, so they certainly have more push and influence than we would as the lowly nonprofit. So when they talked to MB Housing and then they said, yeah, we can commit to giving you some rent subsidies a year. I have not seen it on paper yet. That is a verbal agreement, and so we are working on an MOU so that we can stick to that. if that falls through in future years and they say, oh, we don't have any res subsidies left, like future projects, that'll be your place to live. And it's really the only reason was because it's 6 units. We want to be able to help as many people as we can. And so that was the crux of that transitional model. And so hopefully it'll work in future projects. If we keep doing this, maybe they won't be, and it's fine either way, so.
So for us, originally when we ran the pilot for 2 years, there was a 30-day stay limit, and that didn't work. And we knew that it wouldn't work. So our goal was working with the Alberta government to say, okay, if Taylor, who has a job and a car and a bank account and some credit, can't get an apartment in 30 days, to expect anyone with a brain injury coming out of hospital and maybe just lost their leg to frostbite is going to do so is absolutely insane. So we made it goal-centered. So as long as you're working on a goal, you can stay in the program. So like Bridget said, shortest stay is probably 3 days. Truthfully, probably shorter than that, because someone came immediately from hospital, realized they're now in a housing program, and was like, oh crap, I don't want to show you my bank account, so I'm going to leave. But the goal is, as long as you're working on appropriate housing, so that housing might not exist. We have someone in Bridge Healing who will probably die in Bridge Healing because the outdoor doesn't exist. So being a human-centered program, that person will live in Bridge Healing because the goal is to not go back to emergency. So we only have 36 units today, so those bed blockers are a problem, but the dignified human right thing to do is to allow them to stay, give them amazing care, and continue to push our partners to build more housing across the province so that appropriate housing exists.
Thanks, everyone. We are at time. I don't want to keep folks too late because it is lunchtime. The recordings and the slides and contact information will be available on your phone app or on the website as well after you log in. So in case you have any more questions for our wonderful panelists, you can get in touch that way. And lunch will just be back in the plenary room. It's 5:17. Thanks, everyone.